And without further ado, I would like to welcome our panelists and our moderator for the panel discussion. I would like to introduce Arlene Binsek, and if you have been had done any work in this field in the past several years, you'll probably have crossed paths with Arlene. Arlene has very recently retired, working for Christiana Care as a registered nurse since 1979. She became involved in the HIV/AIDS work in 1986, and she was the director of the Holloway Community Program for over 32 years. She's still involved as she continues her involvement with the Delaware HIV Consortium and the Delaware Planning Council, HIV Planning Council. You are, yes, I see, there you go, Arlene. You can go ahead and unmute yourself, and welcome to the panel discussion.
Arlene, we can't hear you as of right yet.
You are muted.
Oh, there we go.
Oh, there we are. I'm in Brian's office, so we're going to be tag teaming, moving back and forth. Thank you for including me, and it's really a pleasure to be with everybody today. It's also a real pleasure to spend some time with three of my very favorite colleagues and people who I know are leaders in the field of HIV/AIDS in the state of Delaware. So let me introduce everybody, and then we'll go ahead and get started. The first panelist is Tyler Burrell. Tyler is the executive director of the Delaware HIV Consortium. He has dedicated his career to empowering and elevating the voices of the underserved population and socially isolated people to foster the changes that they want to see in their community. Before being with the consortium, Tyler served as the manager of the Community Development and Advocacy for a Housing Alliance in Delaware, where he developed, promoted local, state, and federal policies to reduce homelessness. Tyler began his career actually initially with the Delaware HIV Consortium and was very involved in the Delaware Planning Council. He was the manager of that. He graduated from the University of Delaware with his master's degree in urban affairs and public policy with a focus on U.S. healthcare policy. And he has a bachelor's degree in communication. So he's a local person. He was born and raised in Lewis, and he now lives in Philadelphia with his wife and his little baby girl, who I think run his world. Absolutely.
Thank you so much, Arlene.
Yeah, it's good to see you. I'm sharing in the office with Brian. Brian Wharton is the Education and CQI Coordinator for the William J. Holloway Community Program here at Christiana Care. The Christiana Care Holloway Program is the Ryan White medical provider for Delaware. He also serves on the Mid-Atlantic AIDS Education and Training Center as an HIV educator. He focuses on, I know, both HIV care and treatment and prevention, health equity, and community issues in caring for the caregiver, which is really one of his marvelous strengths. He has 10 years of experience as an emergency room nurse, where he was their pediatric coordinator. Brian has his master's in nursing and nursing leadership from Wilmington University. He's the co-chair of PRIDE, which is the Employee Resource Group, and a learner of the Growing Our African American Leaders System-wide, ERG at Christiana Care. And I know he advocates for health literacy, prevention, healthcare equity, and equity for all. So it's good to see you and good to share an office with you. Dr. Cahal is our third panelist. She is the clinical coordinator of quality and safety for the Holloway program. She is an infectious disease physician for the Christiana Care system. She earned her medical degree and her master's in public health from Tulane University in New Orleans. She's accompanied by honors, including the Tulane 34 Award, Achievement Award at Inter-American Friendship and Understanding, and an Infectious Disease Society of America Scholarship. Dr. Cahal is associate professor at Thomas University. She is a member of the Alpha Omega Alpha Honors Medical Society, Gold Humanist Honor Society, and National Scholars Honor Society. She completed her internal medicine residency with the Global Health Track at the University of Washington in Seattle, and was the recipient of a Global Opportunities Health Fellowship, followed by years as a clinical instructor of medicine at Harborview Medical Center. She completed her fellowship in infectious diseases at the University of Pennsylvania. So Dr. Cahall has conducted HIV/AIDS research. She has co-authored articles published on AIDS and behavior and presented lectures, teaching sessions, grand rounds. I know that she has been very involved in helping train the community, both for PrEP, pre-exposure prophylaxis, as well as hepatitis C treatment. She is a member of the International Union Against Tuberculosis and Lung Disease, the American College of Physicians, and IDSA, which is the Infectious Disease Society of America. And she also is fluent in Spanish, which is extremely helpful. So hi, Deb. It's good to see you again. So I'd like to start with Deb, if I might. I would like to ask Deb, as a physician, and you've worked with the Holloway program now, I think 7 years. I'd like to know what you see have been the most important advances and changes in treatment and in prevention for HIV/AIDS. Deb, you're on mute if you're speaking.
Looks like we might be having some problems with Dr. Cahall. Maybe skip that question and come back to it.
Sure. Okay, then I'm going to jump to Tyler because I can see you smiling. Tyler, you have and your team have been amazingly involved to a high level with the development of what is called the integrated plan, which is the strategic plan for the state of Delaware for both HIV care and prevention, and is a federal requirement at a higher level, not in a very granular way. What, in having looking at that and knowing that the goal is to get to zero, so zero new infections, zero people without the proper medical care, what did you see in putting that together that you feel would maybe be the bigger barriers that we might face as a state in getting to that goal?
Sure. Arlene, thank you so much. I do not feel worthy to be sitting on this panel, but I am certainly glad to be here. As Arlene said, I'm coming from it in looking at this system on a holistic system side of it. The Delaware HIV Consortium does provide a swath of prevention and care services, but we were founded to really help bring this community together to advocate for how we're going to end our HIV epidemic here in Delaware. And so we have a long 30-year history of doing this community planning work, which really culminated over this last week in the submission of the state's newest integrated HIV prevention and care plan, which will serve to guide us as a system on how we're going to improve ourselves from this year, 2022 through 2026, with our ultimate goal of ending the HIV epidemic here in Delaware. So this is a plan that addresses how our entire system is going to improve itself. And so to develop this plan, we needed to think of the system as a whole. And so we have realized that we do have a very unique system in a sense that we only have one public health system throughout the state, and that can lead to some real benefits, some economies of scale, and some efficiencies here, because we're only dealing with one set of funders per se, and really it gives us an opportunity to test out new things here in Delaware, which might be a little bit harder in the state of in any other jurisdiction that has to deal with multiple public health systems. So one positive here for us now. Now, some barriers that we are going to be considering, that we have considered as challenges, is that we do have a limited number of AIDS service organizations in the state. And so anytime that there is a large challenge to our system, say, for example, a closure of an AIDS service organization or closures of infectious disease clinics, then it creates a real challenge for us to, as a system, bring in the rest of our clients and make sure that no one falls through the cracks. And so, for example, we had a closure of one of our AIDS service organizations in early 2020, Kent Sussex Community Services, and that left the remaining two case management agencies to come together and try to assume those extra clients, which adds real stress into the system. Now we see that As a challenge as well, and when we're considering our professionals who are in our system as well, it seems as though the state has a graying HIV workforce population. So there's concerns that anytime that we don't bring new professionals into the system, then we're not going to be replacing the existing professionals, and that can lead to some real challenges as we try to provide HIV prevention and care services, and again could lead to people falling through the cracks, particularly if clients that we want to address and provide service to don't see workforce that looks and sounds like them as well. So things that we need to consider there. Some other stuff that we want to consider as a system as real challenges is we don't, for example, we don't have a strong, robust LGBTQ community, a supportive community. And so it's hard to advocate for one of our largest populations, the MSM, men who have sex with men population here in the state of Delaware, because we don't have that one natural service organization or culture community to advocate for that population outside of, say, Camp Rehoboth in Delaware. So some of the things that we want to be thinking about, and really lastly, that I wanted to mention here at the top was that our population, just like every other population, has to deal with the same issues that the overall general population deals with, the shortages in healthcare professionals, the shortages in mental health, dental, and the like. And so it just has an add-on effect to the other issues that we as an entire sector need to deal with. So I know I touched on a lot, but if you have any questions in there, I'd love to address them. Arlene, you're on mute. Oh, man.
You know, I think Brian enjoys being able to put me on mute. I'm just saying. Deb has joined us, so the three of us are in the same room. So we're going to flip our camera around, and I think that's excellent. And I think those are some very important points to have touched on. So I'm gonna flip to Brian now. A couple of things that Tyler mentioned are really things that are faced on a national level, and your experience with the ATC kind of highlights that. Can you sort of touch on that as far as workforce development, and also what do you see in your dealings both nationally and with the program? Are some of the strengths that we've probably got challenges, but what are some of the strengths that you think Delaware has in being able to address some of these barriers?
Sure. So, good question. As a leader, I think my most important job is to take care of the caregivers who do the work. You know, HIV is still an epidemic. We're still doing the great work. We have a lot of work ahead of us with HIV care and ending the epidemic. So to do that, you need a workforce, right? And the workforce looks different than what it did 20, 30 years ago, right? So along with that workforce, when we're talking about even national level, is getting the newer workforce connected to the HIV mission. So the HIV mission, and I mean, I've had the pleasure of working with Arlene, who lived through the early ages of HIV, and we did that work where they had those memories, they had those connections to that the deadly disease. Now it's not a deadly disease. It's actually called a chronic care disease, which I don't think that name chronic care, it kind of makes it sound not what it is. It's still a public health concern. It's still an epidemic. So we need a workforce connected to that. This is not like your asthma and your diabetes, right? This is still a public health concern. And this is still heavily contagious and easily acquisition should we not do the education that we need to. I'm a big proponent in education. So when we look at the workforce nationally, the workforce kind of, how do I say it? It's kind of comes and goes, right? We have a lot of staff turnover. You can call it COVID, you can call it generation, you can call it whatever you want. The staff workforce kind of comes and goes. So with that, I think what we need to do is we need to look at different types of staff that we have, right? Tyler brought up a very, very good point where the face and the voice of our program needs to meet the face and the voice of our patients, right? To do that, guess what we need? We need to be able to look at our caregivers. Our caregivers And, you know, our Black and brown caregivers are dealing with the same social determinants of health, the same racism, the same issues that our patients are. We need to build supportive programs for our staff. We want diverse providers, right? But we don't support them well internally. We do have care for the caregiver. We do have different things that we do, but not specialty stuff. Like, how do you deal with trauma? How do you deal with racism? How do you not internalize that? How do you build resilience? We always talk about something called the why. Your why is why you do what you do, and that shouldn't change. And if it does, then that's an evaluation you need to do, right? Why is it changing? But the where you do it, the how you do it changes every day. It changes here. But the why you do it is, it just doesn't change usually. So we need to connect into that. But I got to tell you, when I look nationally, and then I look at Delaware, we are so lucky to be in Delaware. When a few words describe Delaware, and I always say the Delaware HIV service delivery and prevention care delivery system, it's a collaboration, not competition. I love that because it takes everybody from HIV Consortium, AIDS Delaware, Bringing Home Counseling. It takes everybody who is testing, who is out boots on the ground with our patients. Christiana Care, we're a referral source, so we're waiting for you to test them to bring them to us, right? And we do some testing. We dabble in testing, right? We're also working with the ED now to do testing. So we need all of our community partners to help end the epidemic and to control and educate. Anytime you can educate, and the one thing we need to grab onto as a workforce is not just the HIV care and prevention workforce, it's primary care doctors, it's social workers, it's everybody, even outside of us. It's a full team approach. And the thing we need to remember, and the thing we need to promote the most is a status neutral approach. Everyone gets tested. It's no longer the provider stereotypes or does an assessment to get people tested. Everyone gets tested. So I think in developing that workforce, you also have to make people, one, feel connected to the mission, but also that what they do is a piece of that chain. And if that chain is not connected, the service delivery doesn't work. And I think that's what's so good with Delaware. And the one thing that the AETC does is keep all that connected, help with the education. And there's not much that we do that the other counterparts, the other team member, agency members don't know. And I think that transparency helps too.
Thank you. So Jeb, I'm gonna turn to you. You are a highly trained infectious disease physician. So number one, I'd like you to express why you became involved in HIV/AIDS really as a primary focus, I don't know if I say, of your career. And then number two, what has really excited you in the last, year or two, the changes that have occurred in HIV prevention and HIV treatment management that get you excited and that you think are game changers? So two-part question.
Thank you for asking me a question that I prepared for.
I tried.
I wanted to give a succinct answer to the first part, the first question. It's a complicated one, and it actually goes back a long way to when I was in college in Philadelphia at the University of Pennsylvania. And I had work study jobs through college. And it just so happened that my last work study job as a senior was at the AIDS Clinical Trials Unit at the Hospital of the University of Pennsylvania. This was under the mentorship of Dr. Pablo Tebas, who some of you may have heard of. He's really a luminary within the field of HIV, not just nationally, but truly internationally. And not to date myself, because I do have a birthday coming up, but this was back in 2004. So we're talking over 15 years ago. And in this role as working in this work study job, I had the opportunity to effectively watch Pablo, to shadow him, and he's truly a master clinician and researcher. And this was at a time, 2004, when there were still relatively limited treatment options for patients living with HIV. And they were still seeing a lot of patients presenting with extremely severe opportunistic infections. And so it was during this time that I was really inspired by the rapport that Pablo had with his patients. I found the field itself to be really exciting. The advancing science of the field at the time, which I'll get to this, still exists today, the immunology, but probably most importantly, the patients. And in following him and spending this time with him, I was just really energized by the staff, by the patients, and by the disease process itself. And so, honestly, up until that time, I had never considered myself to be medical school material. However, it was really Dr. Tebas who, through this job, encouraged me to prepare and ultimately to apply for medical school. And in fact, the whole story comes full circle because I ended up in Seattle for internal medicine residency, so about as far as I could get from the East Coast. And then I returned to complete infectious diseases fellowship at the University of Pennsylvania with Dr. Tebas as my mentor, and he truly is still one of my greatest mentors to this day. So that's a quick history as to how I found myself in the field. As to the second part of the question, what do I see as some of the most exciting advances and things to come? So, since the advent of ART, there are over 35 antiretroviral therapies created to date, and we've come from obviously regimens that were extremely challenging to take multiple times a day, huge food requirements, acute and chronic toxicities, just extremely difficult regimens to a point where the vast majority of patients, if they take their medicine as prescribed, can be on a single tablet regimen, a 1 pill once a day regimen. In addition to that, we've seen the advent of different delivery systems, most recently injectable ART, as well as injectable PrEP. And these are really game changers because I think we're now at this really exciting phase in the epidemic where we want to end epidemic. And I think the way that we're going to do this is we've got to figure out how to reach patients where they're at. And so the right therapy at the right time is going to look really different for different people. And so for some people, it's still going to be a 1 single tablet regimen of 1 pill once a day. For some patients, it's going to be coming into clinic every month or every other month to get an injection or every other month to get injectable PrEP. And even this year, there's going to be some new things coming, subcutaneous injections every 6 months for multi-drug resistant HIV. So I think the field is still very much not stagnant. There are so many exciting changes still to come, and most of it surrounds the delivery system for antiretrovirals or PrEP, as well as the implementation of getting these technologies to the patients who need it most and to the patients that we're not reaching, and we know who they. We just have to figure out how to do it.
That's awesome. Thank you so much. It seems like we have had certainly the challenges of the last several years. The COVID has had a tremendous impact. But frankly, perhaps more on the prevention side, certainly we feel, and I believe in our support, that people being identified, getting tested, knowing their status has been affected, as well as for some patients, a higher sense of isolation. How do you, and I'll start with Tyler, because you guys are very involved in case management and in providing and coordinating, so a lot of the supportive pieces, how do you feel that COVID has impacted both perhaps your workforce as well as the patient population we serve?
Yeah, sure. So here at the consortium, we did an interesting thing when the COVID pandemic started, which was we brought in researchers to evaluate the impact of COVID-19 on our population. We know that Delawareans living with HIV are living on the margins in many instances, and so one shock to the system can get you to fall off that precipice, right? And what we did find in doing this work was yes, many of our populations were living paycheck to paycheck, and so a shock like COVID-19 would have a severe rippling effect that could knock people out of HIV treatment. And so we wanted to make sure, and luckily the system is pretty robust, so we wanted to make sure that we could surround all of our clients and all of Delawareans living with HIV with supportive services. So in terms of emergency financial assistance, in terms of case management services and referrals out, food services and the like, to make sure that, you know, we are dealing with a very isolating and very shocking COVID-19 pandemic, but that we wanted to make sure that you weren't going to be able to fall out of care afterwards because of that. Now, you know, that's just a quick background, but I also think that in many instances, what COVID-19 did was highlight things that were kind of cracks in our HIV care and treatment system and prevention system that were there to begin with. For example, we know now, and we knew then, that we're largely providing HIV prevention and treatment services on a typical 9 to 5, Monday through Friday course. And in many instances, people living with HIV or at high risk for HIV don't have have work as well, and so can't get to HIV prevention or treatment services in that 9 to 5 setting, right? And so we need to be considerate and concerned with making sure that we can provide outreach and HIV healthcare on the schedule of the clients who need it, right? And so it's something that we still need to work on. Another example is, you know, this COVID-19 pandemic really highlighted, access challenges for HIV treatment. And one course that we took was providing everyone an opportunity to have telehealth. Well, in many instances, a lot of our populations don't have familiarity with the technology needs or technology needed to do telehealth services, or have the technology themselves. And so we need to ensure that, telehealth is not going to go away, but we need to make sure that we aren't further exacerbating existing disparities, because the people in our population that we need to be most concerned with are the same ones who don't have access to that telehealth already. And so we need to be, as a system, be ready to scoop up and surround ourselves with those individuals who might fall through the cracks by our new systems that we're putting into place. And I'll stop there.
Yeah, I think those are very good points. Deb, from a provider standpoint, and I know not just the most recent, but the fact that we're being faced with the flu season, as well as the impact of, and what is in the news, RSV as well as COVID. What are you seeing on a provider side related to the current state, and also related to the COVID pandemic on our work?
Thank you for the question. Honestly, in thinking back about, these past 3 years, particularly the first year of the pandemic is for me personally, as it is for probably many of you and your families and your clients, it's painful. So many of our patients, as well as our program staff and family and friends, really suffered deeply during this time, and unfortunately continue to do so. The pandemic is not over, although some have said. We know that due to social determinants of health, which Tyler pointed out, that our patients often face, and this is opposed to having HIV in and of itself, which at this point in time has been very well proven. If it's well controlled, again, in and of itself really isn't an additional risk factor for our clients to have severe disease, hospitalization, or death. But what we know is that, again, to Tyler's point, these underlying social determinants of health and pre-existing conditions have really impacted most severely how our patients have been affected throughout this pandemic, be it directly or more often indirectly. So during these 3 years, I personally, within, thinking just about our program and our clinic, I observed a significant drop off in patients, both newly accessing as well as persisting with PrEP services specifically. And I think that state data probably highlights this as well. I think that statewide HIV testing during the pandemic, again, more so during the beginning, was definitely down and has started to rebound and kind of get back up to where it was. But there was a definite drop in there that we felt on the clinical side of things as well. Speaking more toward accessing HIV services to our patients living with HIVs, I feel like our program did a really, really good job of hanging on to our patients during this time. Really, in the entire 3 years, there was 1 month in there, I want to say it was around April or May of 2020, where we had to convert to fully virtual visits. And most of those visits, because patients weren't set up, they didn't have access, it came upon us really quickly and the tech wasn't there. We did by phone. So there was that month that was really, really challenging. But then after that, honestly, the bulk of our patients came back to access care in person, which I think truly was to the benefit of the patient, because so much of what we do requires or is better with face-to-face interaction. We have all these wraparound services that we can do at the same time. So making sure we're getting labs, that light is being renewed appropriately, connecting patients to other services. So I think, it was very, very challenging, but our program did a really good job of retaining our patients who were already with us, retaining those patients living with HIV impaired. And, to this day, we have a very small cohort of patients who elect to access care virtually, be it all the time or some of the time, but it's a very, very small number. And, these are patients with really extenuating circumstances, be it transportation, childcare issues, mobility issues. But at this point in time, even with the syndemics of RSV, flu, and COVID that are again upon us and that we're feeling this fall, our patients want to come in, and they're so happy to be able to come in. Thinking about what this season is going to look like. Obviously, for many people, we've been more back to business than we have ever been in the past 3 years. So people are, in the community, they're unmasked, they're engaging in their normal activity, trying to get back to a new normal. And the pathogens are catching up with us. So it is an early severe flu season. Hospitals, both locally and nationally, they're inundated with RSV, with flu, more so than COVID, though COVID is obviously still extremely important, and we're continuing to encourage our patients to be boosted appropriately. So it just highlights the importance of keeping the spotlight on these things and making sure that, again, although some have said the pandemic is over, it's not, it's still here, and we still need to be vigilant, both from a staffing perspective and a client perspective.
Perfect. So Brian, I know a lot of the work that you do is monitoring clinical outcomes for the program, and supporting those clinical outcomes. So I do know that on a national level, there has been a deterioration from COVID of undetectability among, some areas of the country. Could you speak to whether or not we saw that here in Delaware, number one, and number two, getting back to the comment, Deb, that you just made, I know you have all spent a lot of work around performance improvement for flu immunization and acceptance from our patient population of flu immunization. So I'd be curious as to how is that going this year, because I know we had a really successful year last year. So I'd be curious as to what that looks like.
So as far as you're right, there was a drop in undetectability, but let's talk about that for a minute. Here in Delaware, we didn't see such a severe drop. And I gotta tell you, I think for a few reasons. So when you think about a drop in undetectability or let's talk about viral, we'll think about all the steps and sequence that have to happen for you to do that. Our patients, just to get into Tyler's office, or just to get into AIDS Delaware's office, or to get up through our elevators at the Holloway program, they have to feel safe. It takes a lot of bravery for them just to come through the doors. And we saw that during the COVID-19. We had patients return who were lost to care, who returned. We also only went down capacity to 60%. We still saw most of our patients face to face. So the other part of this that I want to say, when we talk about numbers, it's great to see that Delaware does a great job with undetectability and viral suppression and all the other metrics that we do a great job in. But you really got to break that down. Here again, takes the whole care delivery system. I know that the case manager, the community case managers, they convert it right away to virtual and the phones to still keep that connection. Our patients want to see us. We are their support. They need that human connection. They need people to understand. And I know some of the things we do, like, oh, why do we have to do that? Or this is a pain in the butt. But the thing is that we're caring for our community the way that they need it. And quite frankly, the virtual, the access, that was an access to, the electronics. But the other thing, they don't want to do that. A lot of people don't trust it. We had to have conversations of, hey, are you at work having your video visit? Because you may not want to discuss these things. So we had to kind of have that conversation. So when we think about undetectability, and Arlene, you would know also about this, I don't think we went down that much. I think maybe 87, 88. but we're right back up to 91, 92, where we set in Delaware for a long time. And I think the reason for that is that I keep saying this, but the delivery care system we have, the chain to and the linkage to care that we have. I know, and Arlene, you can attest to this. When COVID happened, it wasn't just Christiana Care, it wasn't just AIDS Delaware. You guys, did virtual meetings weekly to keep the care. I mean, so everybody knew what everybody needed. If somebody needed something, like if Tyler's group needed something from the patients and they came in, we got it. So it was that connectedness of care. So I do want to say, you know, undetectability in Delaware is back to 91.2%. And we did not drop, and I think it's because of the delivery care system. I do want to speak to one thing that Deb was talking about is the fallout of COVID. I have to tell you, on staff side and in the side of patients, I think the long-lasting fallout of COVID that we're going to look at is mental health. So we really, as a system, we'd be naive not to throw mental health at every corner we can. And we're also talking about staff mental health. You know, COVID, seeing that, relates in a little bit of way to the early HIV AIDS epidemic where people were dying. I'm still an emergency room nurse, and the way I cared for patients during COVID and the family members could not come visit them when they died, that's different. So that can have a big impact on the caregivers, but also the patients. They were afraid to go get their meds. They didn't want to come to their visits. They didn't get the health care. Also, the burden that it had on the epidemic with closing down testing sites and not having that. And we're picking right back up with, well, we only have this many patients, yeah, but we only did half the amount of testing maybe. So getting that education back out there, you know, reasserting, you know, that HIV is still, people are like, oh, it's not a big deal anymore. It's a big deal. It's a real big deal. But also, I think the thing is, what we do well in Delaware is the holistic care. It's a very little, and Deb, don't take offense to this, but very little bit of it until you get to the doctors about medicine. The rest of it is social determinants of health. The rest of it is, you know, those high-risk behaviors that may have put you in danger of acquisition HIV. Let's get that together. Mental health, let's get that together. I know the community agencies like Tyler's and AIDS Delaware, and they provide that holistic care where they're supporting them with housing and transportation and really that Maslow's hierarchy. So it's getting them to their appointments, but also keeping them virally suppressed and going viral suppression, which takes a village. I know that's said all the time, but this is truly the village that can help keep that undetectability and help with the end of the epidemic of HIV.
Before we get on flu immunization, I do want to shout out too that it's something that you said, getting back to the fact that we worked so collaboratively. You know, we are very lucky when we talk about what is different in Delaware. What is different is that level of collaboration, both with public health as well as with the private sector, community organizations, as well as the healthcare system. So and certainly the experiences that I had for many, many years, is feeling very, very lucky with those relationships and the ability to work collaboratively and problem solve collaboratively. So I don't want to leave that unstated because it's been incredibly important. So how is flu immunization going? With all of the things that are on the news, is that helping or not helping people wanting to get their flu immunizations this year?
Yeah, but that's a great question, and for this year in particular, a really, really important one. If I may, I'd like to share a little bit of background on some QI work we have done within the Wilmington site here at Gateway, and then programmatically surrounding vaccinations. I think it's very pertinent, not just to influenza vaccination, but also COVID vaccination, monkeypox vaccination, and then of course just age-appropriate vaccination. So back in 2020, first year of the COVID pandemic, we started a QI project this year in Wilmington, looking to raise our already pretty high influenza vaccination rates amongst our patients. So if you kind of think about the country at large in a given year, for all comers, for all adults, about 50% not even will get an influenza vaccination, which is pretty low. Our program leading up to 2020, in a given year, at least a couple years preceding COVID, we were sitting closer to 65% of our patients getting influenza vaccination. So that was already higher than the national average, and actually already higher than other similar Ryan White funded clinics. We probably sit at about 57% vaccination rates. So in 2020 to 2021, not knowing what the influenza season was going to look like, we sought to increase our vaccination rates. And we did this through a variety of ways, but really the end result was ensuring that influenza vaccine was discussed with the patient, and not just by providers, but with anybody that they came into contact with the clinic. And through a multimodality approach, really coming up with a variety of ways to nudge the patient and remind them, whether it was visually, verbally, electronically, what have you, that influenza vaccination is here and we should all be getting it. And through this multi-pronged approach that really involved all of our staff, from when the patient walked in and met with the OA and was checked in, to when they, saw the provider or the social worker and was checked out by the nurse. Everybody had a hand in speaking to that patient. And so through these efforts in 2020 to 21, we achieved 85% influenza vaccination coverage within our clinic, which is pretty impressive, because there's usually going to be 10-15% of patients that do not accept vaccines and are extremely hard to reach. We then did this again for the 2021 to 22 season, but we included our entire program throughout all 3 counties in Delaware. And again, irrespective of county, we achieved an influenza vaccination rate for a second year running of 85%. In retrospect, it was good practice because there wasn't much circulating flu for those 2 seasons. But this year, as the Southern Hemisphere and our experiences to date teach us, it's a very, very different story. And so this year, one of our nurse practitioners based out of one of our southern sites out of Georgetown is leading the initiative through a multidisciplinary similar approach to again achieve these rates of influenza vaccination among all our patients living with HIV. And what we've seen, and again, the focus has been influenza vaccination, but even for our patients, we know that close to 85% have received at least one COVID vaccination today. And I can't give you the exact figures on monkeypox vaccination for eligible patients, but I would suspect it's similarly high. So I think the work we've done these past few years has really prepared us for this year where it matters all the more.
That's great. Great information. And yes, I agree. There's a lot of commentary about vaccine fatigue. I think we can all appreciate that, but laying the foundation and facing what we're facing this year is important. I'd like to touch on one more thing before we see if there's any other questions, but you mentioned, Brian, the role of primary care docs. You mentioned the role of primary, and really this is for you, Deb, as well, more perhaps as a physician. What do you feel, or what do you see are the important activities that primary care physicians, specialty physicians should and can be doing to help us achieve that zero, getting to zero, and helping us with the work that we're doing?
Sure. So a lot of the work that I did for ATC and just looking at, how can we leverage other resources outside of our HIV, right? Because we need everybody in this fight. There's a lot of resources, but I think it's a lot of, I don't think it's unwillingness per se, but I think it's like, oh no, that's HIV, they'll handle it, or that's STD, ID will handle it, or that's something else, they will handle it. It's almost giving permission to people to be on the team. Hey, we need you. It's kind of like the army, we need you, or we want you. A lot of education around. So I think one of the barriers is primary care. Let's talk about that real fast. And I'm not saying primary care is the barrier. They have a different rhythm, right? They see you for 15, 20 minutes. They have to get all your screening done. They have to do all this checklist of stuff that our healthcare is now mandated, right? So HIV, sometimes even just offering the test is lower there on the threshold when they have a lot of different things. That's why I think that the status neutral approach is a big win if we can get people to invest in it. There's opt-out testing now. You can make that like when you go to get your cholesterol, go on an HIV test. Have conversations. We do a lot of work around having a conversation about sexual health is uncomfortable. It takes more than 20 minutes, and you don't even have 20 minutes to do it, right? So I think that, letting people know also that it's not going to impede. Here's some quick things you can do, and it's not going to impede your workflow. This will, and showing the medical people the data, how, we're referrals. So where are we getting these referrals from? We're getting them from outside providers. We're getting them for the HIV testing. We're getting them from primary care offices. So they are part of the team. I think another source, and we're heading up a project now, Dr. Cahal and I are involved in a project with the ED, the emergency department, testing for HIV. When you come in and you have high suspicion or you're being treated for STDs, STIs, high-risk behavior, get tested for HIV. And guess what? If it's positive, we'll take it from there. If it's negative, the state has the prep resources. We have education. So we got your back. Do the testing and we'll take it from there. So I think it's really important that we collaborate and we educate even ourselves as healthcare providers. And when I say providers, I don't mean just doctors and nurses. I mean everybody. There's no reason why case managers and social workers can't say, hey, did you get an HIV test? What do you think about that? Talk about that status neutral approach. It's no longer by exclusion. We include everybody in that approach.
Thank you. Last comments. We've got 3 minutes.
Okay, I'm gonna make it quick. I mean, I think Brian hit many of the high points. I would just emphasize that when we're thinking about ending the HIV epidemic, this is not exclusively a specialist fight. This is everybody's fight. And it's been the recommendation for a long time, and it continues to be. And we need to continue to educate our frontline providers that HIV testing needs to be offered as opt-out testing for all. And there are so many touch points when these primary care providers, whether it's family medicine, internal medicine, OB-GYN, the ED, are seeing patients for STIs, for contraception counseling, screening for domestic abuse or substance abuse. These are all natural segues to expand the discussion to discussing HIV screening. So I just want to, really encourage folks to not consider this a specialist, thing. This is everybody's thing. And we as specialists and those who have access to resources, we need to make sure we're continually getting out there and utilizing our resources like the AETC, our community collaborations, being accessible to everybody to ensure that if providers are taking that step and doing this testing, they feel like they have support in the next step when that testing comes back, either positive or negative, because either way, there's a branch point. If it's positive, it comes to an HIV provider to continue that engagement and care and get the patient appropriately on ART and suppressed as soon as possible, or they're negative and the patient is high risk. And we need to make sure we are linking these patients to PrEP care as soon as possible, because that is also a very important part of the continuum of us actually ending the HIV epidemic.
That's awesome. That's awesome. Thank you guys so much. This has been a real pleasure. And I hope this has been valuable. It is 12:39, and we're going to turn it back over to Suzanne to take it from here for the prep conference. So thank you all. Thank you both. And thanks for sharing the office with me.